Thank you very much, Dr. Sotomayor, and thank you everyone for inviting me up here today. So today we'll be discussing a case, the buttons worked, excellent. So this is a diffuse large B-cell lymphoma transformed from follicular lymphoma. It's a 39-year-old male, no significant past medical history. He'd initially presented with hypercalcemia, lymphadenopathy, hepatosplenomegaly, and bone mets that actually had caused an L2 compression fracture. At the time, the biopsy showed follicular lymphoma. He did not have any known evidence of high-grade lymphoma. He did not have any insurance, so he was not able to get a PET or any real systemic therapy. At the time, the local oncologist he was working on getting insurance, so he was just managing them with courses of prednisone. So it was working for a couple of months. The prednisone would kind of calm the symptoms down, his LDH would come down, but he got admitted multiple times. He ended up at TGH about 3 months later, worsening lymphadenopathy, worsening cytopenias. He had obstructive nephropathy. He actually received bilateral nephrostomy tubes. CT showed, of course, significant hepatosplenomegaly, worsening lymphadenopathy, and then bone mets that were actually worse on presentation. Lymph node biopsy at this time confirmed that it was transformed to DLBCL. The bone marrow biopsy still showed follicular lymphoma. There was no evidence of high-grade lymphoma in the marrow, but definitely high-grade lymphoma was found in the lymph nodes. Classified as GC type, Ki67, 80%, not double or triple hit. And then this is just an overview of the mutations. Maher, Dr. Albitar will come up and go into more detail.
Thank you. Have a seat. So as you can really see, there are numerous mutations here, and in addition that we can also demonstrate the 14, 18 translocations, and more importantly are the chromosomal abnormalities, the multiple chromosomal abnormality as you can see here, and clonalities. Let me go into more detail. So these are the detected mutations, and they are all very much relevant, especially EZH2, which is typically we see in follicular lymphomas. Then you get B2M mutations here. There is mutations in TP53. And when we look at clonalities, as you can see here demonstrated by the level of very high level for immunoglobulin heavy chains, as you can really see here, very high clonality here. But when it comes to the light chains, and this is really very interesting, we see this frequently with multiple myelomas as well. There are 2 clones when it comes to the kappa. So it is not 1 clone for the kappa, there are 2 clones, but 1 clone for the heavy chains, versus there is no clonality at all when it comes to the L. So with the lambdas. And these are the chromosomal abnormalities. Chromosomal abnormalities in lymphoma are extremely important because they give you an idea about the classification of that type of lymphoma. So here, for example, this particular lymphoma, you get the TP53 deletion on the 17B here, in addition to -4 deletion here, and as well as on chromosome 10 and chromosome 15, in addition to trisomy 18, which is also very important for the classification of the type of lymphomas. Now, this is actually the fusion for the BCL2. I must really point out that frequently we don't really detect the fusion when it comes to the immunoglobulin, because as you all know, most of the chromosomal translocations that involve, let me say, BCL2 make they practically translocate the gene of interest, whether it is MYC or BCL2, into the promoter enhancer region of the immunoglobulin. So what we see significantly high expression, But sometimes on the RNA, we can really detect that fusing, which is a small part of the immunoglobulin, as you can really see it here. And this is the BCL2 genes, but not all the time we see the translocation or catch the translocation, but we catch the overexpression of the gene, and this is when we start reporting it as high expression of, let me say, MYC or BCL2, consistent with promoter hijacking, because it is hijacking the promoter or the enhancer of the immunoglobulin. But in this case, we detected that, and this actually also we have classification for these types of lymphoma. As you all know, there are multiple classifications now out for diffuse large B-cell lymphoma. One was driven by the NIH, and the second one driven by the Mass General, in which subclassified the lymphoma based on the expression and the chromosomal abnormalities, and the Mass General classified them into C1 to C5 versus the NIH classified them differently. And we did actually study based on more than 550 genes, 550 cases of diffuse large B-cell lymphoma. And based on the expression profile, we can really classify, to make it simpler, we can classify these lymphoma actually based on whether they are GCB versus ABCs. But we divide the GCB into two groups, that one is low grade and the one is high grade. This is actually what we reported on this particular case. This is really still GCB, but it is with the high grade, as you can see, very close to the ABC, actually, as you can really see it here. And this is actually from our a separate paper, which actually use similar approach based on the expression profile, but here actually not relying on the ABC or GCP, but using a completely different classification based on the expression profile, but give us the same things. We published this paper actually a few years ago in one of the papers. But again, this really gives you an idea that the ABC and GCP are not one group, and they are some very aggressive in the GCP that could be similar to what we see in the ABC, as you can see here. Now, when it comes to diagnosis of diffuse large B-cell lymphoma transformation from follicular lymphoma, this can be a very difficult topic for pathologists. And frequently I get question from the clinicians and say to me, well, this case was classified by the pathologist as follicular lymphoma, but the patient not behaving like follicular lymphoma. It is very aggressive disease, So we developed actually, of course, there are some signs which will tell you that this is more aggressive, and in particular, chromosomal abnormalities. So we look at the chromosomal abnormality in particular, and the more complex chromosomal abnormality, this is definitely not follicular lymphoma anymore. So, but at the same time, we use this AI actually driven, and this particular case actually, which is interesting, it classified between diffuse large B-cell lymphoma and follicular lymphoma, but very close to each other. And this is, using actually random forest classification, but using clustering. This case, which is presented with a crosshair here, actually it is leaning more toward the follicular, which means like it has still follicular features, but definitely overlapping with the diffuse large B-cell lymphomas, as you can really see here. And this is unsupervised clustering, and it is, again, it is still clustering more towards the follicular lymphomas in terms of its biology, which is really very interesting about this case. And yeah, and I want to stop here.